Hello and welcome everybody to today's Observatory webinar, this time on a Thursday instead of on a Tuesday. Today we will talk about the important and clearly popular topic of AI in health. We all use artificial intelligence every day, whether we know it or not, in health. It has huge transformative potential, but there is a lot of hype and at the same time a lot of fear. So when it comes to policy around AI in health, it is important to understand both sides and figure out how to make the best possible use that we can. Today gives us the opportunity to discuss this topic from different angles, but it also gives us the pleasure at the Observatory to introduce a recent book that we have produced on the issue. We have a stellar group of panelists who will engage with you, including Martin McKee from the London School of Hygiene and Tropical Medicine, and who is also one of our research directors at the Observatory. Paula Del Rey, also from the London School of Hygiene and Tropical Medicine and the Royal Free London NHS Trust. Judge Jasson, also from the Royal Free London NHS Trust, but also the AI Centre for Value-Based Healthcare in the UK. We have Tino Martí from the Department of Health in Catalonia, and Benoit Verhus from Mission Publique in Belgium. And we will hear from all of them, and also would really like to hear from you. Of course, we have many of you with us today. We're really happy about that. So before we turn to our panelists and our speakers, a request to you to, of course, if you want to engage with the panels and with each other, use our chat function. My colleague Erica Richardson is keeping an eye on it and will reflect all of your inputs from the chat to our panelists later for the discussion. Please do that respectfully and constructively, and we really look forward to seeing all your insights and your perspectives along with our speakers during this webinar. Without further ado, let me pass on to Martin, who has been the driving force behind the work on AI at the Observatory. Martin, tell us about our newest products.
Thank you very much indeed, and hopefully you can see my slides. So, a little bit of background on this. In the observatory, we were very much aware of the fact that everybody was talking about AI, but although they were talking a lot about it, there was a lot of confusion, and it was clear to us that we would have to do something about this. We had detailed discussions with our partners, with our collaborators, and what became clear was, first of all, this was a really difficult subject. It was incredibly complex. There were a lot of words, neural networks, machine learning, large language models, all sorts of things, and nobody really knew what they meant. And even some of the words that they thought they knew what they meant, like hallucinations, seemed to be transmitting a sort of transposing a human dimension onto what was effectively a machine. And even for those who did understand a bit of what was happening, they didn't know what to do about it. So we felt we had to do something. What we needed to start off by doing was to find out what health policymakers really need to know. We don't expect them to design the tools themselves. Clearly, that's something that somebody else does, in the same way that you don't need to know how the microchips in your PC work. But then we also needed to look at guidance in terms of how you apply these things, and in particular recognizing, like any technology, from nuclear energy is a classic example. It can be used for good, but it can also be used for bad. So what we then did was to think a bit about our audiences, and it became clear to us that there were many different audiences that we were trying to engage with. There are people who just think that AI is the solution to everything. The real enthusiasts who think that it will take over all of our jobs and we'll all be made redundant. It will save the world. And then there are other people who say, well, yeah, sure, it's got a lot of potential, but we actually want to see what it can really do. And we're just a bit cautious, but we're generally positive. And then there are skeptics who really need to be convinced. They can see that it's a powerful tool, but they're just not sure that they can really trust it. And then, of course, there are people who are really opposed to it for a whole series of reasons. They're worried about who owns the data. They're worried about the decisions that are being made. They're worried about some of the statements being made by some of the people that are in the driving seat in terms of promoting AI, and in particular, autonomous weapons schemes, all sorts of things like that. And then there's probably the majority of people who really don't know what to do about it. So, what did we want to produce as a result of all of this? Well, we had a number of choices, and we started off by thinking, well, there's a well-known series of books on all sorts of topics for dummies, AI and health for dummies. Could we do that? We thought, well, maybe that has some potential. And then we thought about maybe we could look at a Lonely Planet guide to AI and health. But none of these seem to be quite right. So, this is what we ended up having. And here you see the names of my co-authors on this, and you will be hearing, you've already heard from Dimi, and you'll be hearing from all of the others in a minute. So I'll stop at that point and hand back to Dimi.
Thank you very much, Martin, for this really key introduction to understanding where we came from. And I think where a lot of our colleagues who are here today with us probably are standing when it comes to their everyday confrontation with AI in health. Paula, we come to you. You will give us a sense of what we have in the book and also what the key understanding of around AI in health is based on those results. Over to you.
Okay, so thank you so much for joining us. Really excited to be here today, and thank you, Martin and Timmy, for the introduction. So over the next 10 minutes, I'm going to briefly build on Martin's introduction to talk a bit more about the aims of this book. And then I'm going to focus on the existing and potential applications of artificial intelligence in health, as well as on some of the key strategic and ethical considerations. As Martin mentioned, with this work, we were aiming to bridge the gap between those who are experts in health, those who are experts on artificial intelligence, by providing an accessible foundation. So we have a lot of core concepts and terminology on the book, so hopefully people can engage with it regardless of their technical expertise. We also aim to offer a balanced and evidence-informed perspective, so not only talking about the hype, not only talking about the fear, but trying to think both about opportunities and risks, as well as gaps in evidence. And we also aim to look beyond the most commonly discussed applications of AI in health, which tend to be about activity as well as clinical care. So we try to look beyond this and think more about a system perspective. And then finally, we also aim to support informed, ethical, and context-sensitive decision-making, meaning that we didn't want to advocate for a specific solution or recommendation, but rather provide tools so that people could ask the right questions. We don't have time in this webinar to go in depth about what AI is, but I did want to briefly mention that when we were doing work, we were writing the book for the different applications used AI in health, we try to go as wide as possible. So not only looking at the latest generative models, but we also try to look at traditional machine learning as well as deep learning. However, when we are thinking more about the considerations that I will speak to in my the second half of this presentation, some of them are more relevant to the latest generative and foundation models. When we are thinking about applications of AI in health, we can think about it in different areas. One of them is on healthcare delivery and patient care. This is things like clinical decision support, so supporting with diagnosis, providing information on risk prediction. This is something our colleagues from Catalonia will speak about during this webinar. And it's some of the applications that are the most mature, the most well researched, even if there are still limitations. And it's also the use of AI in precision medicine with patient support, tools such as chatbots, as well as some emerging use in surgical robotics. Then there's another area which for me is particularly exciting because my background is public health and health policy, which is around how can we leverage the capabilities of AI to help us better understand and forecast population health, to help us better understand and support behavioral change, use AI in infectious disease epidemiology, so to help us better understand and prevent the transmission of infectious diseases. And then finally also, but really importantly, in communications and public engagement. Then there is an area of research and innovation, which is hugely exciting. For the book, we focus mainly on two, which are on improving clinical trial processes as well as on accelerating early drug discovery. And then finally, there is a cross-cutting theme that probably for most of us is what we are the most familiar with in our daily use, whether it's personally or professionally, which is an operational efficiency. So how can we use AI to automate routine tasks, to take resource allocation and decision making, to take decision allocation decisions as well as on other types of decision making, the use of AI in evidence synthesis, which is really important in research, as well as on training healthcare professionals. What does the evidence say about applications of AI in health? Well, there are lots of promise across a wide range of applications that we saw during our landscape review. But there are also gaps in evidence, particularly around assessing the long-term impact of these solutions, as well as on using real-world data, which highlights the importance for robust evaluation as well as for generating further evidence. In addition, adoption across Europe remains uneven, not only geographically, but also in terms of. So understandably, applications which are a bit more administrative or lower risk are more advanced, while those applications which have highest stakes, as well as those applications at the population level, are still at earlier stages. And there are several barriers which limit the impact at the scale of AI. One of them is, of course, ensuring patient safety, but there are others as well, such as data quality, issues around bias, as well as challenges in workflow integration. So there are a lot of questions that we might be faced with when we are taking decisions about AI in health. This could be procurement decisions, funding decisions, design decisions. For our work, we looked at them from an ethics and human rights perspective, a governance perspective, as well as strategic integration and system readiness. I'm not going to go through all of them because there are many, but just to give a flavor, these are things like thinking about ethical use of AI, autonomy, ability, privacy and data protection, trust, which is important, as well as issues around bias and unfairness. And then questions that a lot of us probably have heard already, such as, is it really gonna decrease the costs on the health system? What is the impact that it's gonna have on the workforce? What is the impact on the environment? How will we ensure the real world value of AI, and what is the necessary data infrastructure? So it's not to say we all need to ask all of these questions every time we are thinking about AI in health, but hopefully this is a helpful set of considerations that might be relevant when thinking about AI in health. So just to share some of the high-level takeaways when we looked at the evidence and considerations of AI, accountability, transparency are extremely important, but they're also really complex, particularly models get more and more complex and larger and become more black box. But it's really important to understand and should be supported by comprehensive regulatory frameworks, robust oversight mechanisms, as well as safeguards. Privacy, fairness, and inclusivity should be built through responsible data practices as well as inclusive design, with protecting civil liberties and promoting access to AI benefits. And sustainable and democratic development depends on secure infrastructure as meaningful participation of diverse stakeholders. Evaluating and implementing AI in health requires looking at technical performance or benchmarking about ethical and economic considerations, as well as a wide range of considerations, and finally to make sure that these issues AI can and reduce costs, lots of, but its benefits will depend on thoughtful integration into the existing systems as well as considerations workforce. As AI becomes a strategic asset in global health policy, ability and international cooperation are vital. So I think my camera maybe just went off, and I'm not sure why.
Sorry, Paula, it's because your sound is a little bit choppy. So we are hoping that,
really?
Because I think it's a connection issue. So we're hoping that by switching off the camera,
okay, yeah,
that it will be better. Thank you.
Apologies for that. So what does it mean? For governments, it's about robust, adaptable regulatory and evaluation frameworks, developing policy which is reflective of human rights, equity, and sustainability, strategic investment into data infrastructure, which is extremely important, and our colleague Justin will talk about that in a minute. And then investment for development as well as digital literacy. And then finally, apologies on global cooperation to align national AI strategies, not only between countries, but also with international and shared goals. And then for health providers and public health institutions, it's about investing in a structured real-world programs, include piloting, monitor and evaluation, ensuring robust infrastructure with high-quality data and clear ethical guidelines. And then importantly, balancing in-house development AI solutions with external procurement and thinking about the long-term implications, disability considerations of both options. And finally, ensuring patient people-centered collaborative approaches that ensure all populations benefit fairly from technological advances. So that's all for me. Just for the sound, hopefully that was understood.
Thank you very much, Paula, for this really, you had a Herculean task to try and summarize this really multifaceted material into such a short time. I think the visuals were really helpful, and I will just highlight the final slide with these complementary approaches for the policy level and then for specific health system actors within the system, very clearly highlighting this is a really powerful tool, but how we actually use it makes the difference. So we set the scene, or Paula set the scene, and Martin set the scene as well, and we will look at specific examples of different elements that Paula already touched upon from different settings. We start with Jasjot, and Jasjot, you will bring us an example related to data infrastructures from the UK. Over to you.
Thank you, Demi, and thank you, Paula. So good morning, everyone. It's a pleasure to be here. My name's Jasjot. So I'll be presenting a whistle-stop tour of the case study in the book about OneLondon Secure Data Environment, which is mainly about how London's National Health Service is approaching the challenge of getting the foundations of AI right. So the key questions is that if we want responsible and scalable AI, how do we start with responsible infrastructure? So this work sits within the AI Centre for Value-Based Healthcare, and this is a consortium that brings together NHS organisations, academic institutions, and industry partners. The focus isn't just building models, it's building platforms, data infrastructure, and deep data assets. And this all makes AI usable in real clinical settings. And crucially, it supports the full AI lifecycle, from development through to deployment and evaluation. And this is across patient care, population health, and research. So this is not an isolated innovation, it's a system-wide effort with multiple partners. So as you may already know, there are many challenges of embedding AI models into healthcare systems, and the NHS is no different. There are several structural challenges that you might relate with. Firstly, there are many electronic health systems across the NHS, meaning data is fragmented across these systems. That can include blood results, imaging, clinical notes, for example. On top of this, these systems don't talk to each other, meaning there's limited interoperability and data remains in silos. Because of this, our processes are also designed to work with single-use and often one-off data sets, which are static and quickly become outdated. This all leads to processes that can lack transparency, that can duplicate work, and are not reproducible. And so as a result, we end up with limited population insights and AI that doesn't scale. So instead of focusing only on models, our approach has been to reframe AI as it being only as good as its foundations, which are data and infrastructure. So in London, we've prioritised linking and standardised all those NHS health systems into a single format, and that includes the legacy NHS health systems as well. We've also been using natural language processing to unlock unstructured data and all the richness of information that comes with it. And we've been focusing on building reusable data pipelines, which allow a stream of near real-time data, meaning insights are up to date and relevant. So this unlocks AI-ready data that's scalable and sustainable, that has deeper, more granular insights, and importantly, is transparent and governable in its processes. So now our system enables a learning health infrastructure, which means we're able to continuously generate knowledge that feeds back into better care. So this is operationalized in the OneLondon secure data environment through many ways. First, as I mentioned, we use data pipelines instead of static data sets. And this is with high velocity and completeness, meaning local data is used for local models. Second, we integrate development, deployment, and re-identification within the same infrastructure, bringing research closer to clinical practice. Thirdly, we enable monitoring of all aspects on the data platform. That includes data quality, predictions, and outcomes. And finally, this platform enables development responsively and responsibly according to clinical need and pathway need, rather than abstract single use cases. So I hope this has given you a bit of an idea of how we're using responsible AI infrastructure to enable responsible AI. But please do check out the case study in the book for more information. Thank you.
Thank you very much. This was really clear. We go to Tino and we go to Catalonia, and you're going to talk to us about how you deploy AI in primary care. Over to you, Tino.
Exactly. Thank you very much, Dimitra, and also thank you for inviting us to present in this seminar. I would like to give you an example of what is happening at the moment of the application of different AI tools that are embedded in a system-wide reform process that is called Kairos. This is a reform process that we started back in 2024, so 1.5 years ago. And the first phase of this reform process focus on public health and primary health care. And as you can see on the slide, there are many measures that are introduced in 27 primary healthcare centers as pilots to uplift their performance. And I would like to focus on the technology element of these measures, which is this section in the organization efficiency segment. And specifically, we would like to talk about 2 AI tools that we have introduced in these 27 centers and then scale up to the rest of primary care centers in Catalonia. These are a clinical support AI tool. It's a generative AI and also ambient scribes. But this is, one of the messages that I would like to pass, is that this is only a measure within 25 different measures at professional development level, model of care, and organization and efficiency that aims to improve access, quality, and satisfaction of users of primary healthcare in Catalonia. So I just zoom into these AI tools, and I start with the first one, which is a digital assistant. It's in fact a clinical decision support system, which was tested first and then adopted in these 27 centers, and then scale up to the rest of primary healthcare centers in Catalonia. Just to give you the idea that we have almost 400 primary healthcare centers in Catalonia, and this was tested first in these 27. Once this clinical decision support system called Axia is a chatbot that clinicians, and I'm meaning here family physicians, pediatricians, and primary care nurses that are working in primary care settings, they have in natural language the option to ask Axia about diagnostic and therapeutic orientation, and the result of this chatbot is only based on local clinical guidelines and protocols, and it's not looking outside in an open web space. So the result is exactly what, from a policy perspective, is aimed to guide clinicians in their decisions. You can see on this image the evolution since it was introduced back in June 2025, so almost 1 year ago, and how there is a steady increase in the usage in terms of how many prompts or threads within the prompt are query to the chatbot. And we can see, and this is actually reported as a case study in the book, and the figures now are even better that are in the book. We have 91% of satisfaction of primary care professionals. We have an uptake now that has moved from 20 to 29%, which even if it sounds small, we have a base of 20,000 healthcare professionals working in primary care that are potential users of this system, and around 4,500 are already using, and which is for us a very important metric is the adherence, is how many times they use this system, and if they keep using the system, which is represented in the evolution chart. I think the key lessons in this adoption is that first, that we see evolution. This means it's providing value to clinicians in their daily work. Second, for us as a reinforcement of quality improvement policies, it's fundamental to adhere to clinical practice guidelines. You can imagine in a situation where all the information is only paper-based or in documents, that is difficult to manage. And here it's pretty simple. You just query natural language with acronyms, and you get the result based on these clinical guidelines. And finally, and this is like a derived element of this experience, is that we are identifying training needs, analyzing which are the most prevalent queries, and even geographically, we can detect the needs of training for clinicians. And it's also a very nice way of empowering those that have a background that has room for improvement in terms of clinical practice, to improve their practice based on these clinical guidelines. So this is the first one. As I said, we tested in 27 centers and then scale up for the rest of the region. And now all centers are making use of this clinical support. And even the next steps is introducing new clinical guidelines or protocols to improve elements like sick leave management and other elements. This was the first one as part of this reform process. The second one was a proof of concept. In fact, it is an AI agent, it's an ambient scribe that is listening the conversation between the clinician and the patient. And by clinician, again, is everyone that has encounters with patients, so primary care nurses, family physicians, and pediatricians, and is transcribing the conversation in a structured manner, following what is required to then inform the electronic health record. And this has tested with, in fact, 5 solutions. Here you have only the figures of 3 with different levels of satisfaction. The third solution with 80% of satisfaction among health professionals and patients. Usability is also high, and content is high. This is a proof of concept because we tested these 5 technologies in order to learn in the process and to prepare a public tender to select the solution that will comply better with our standards and also provide better value. As a global picture, we query those that tested the system, and this was some doctors and nurses in these primary healthcare pilot centers with 94% satisfaction of patients. So patients didn't feel as an intrusion in the clinical encounter, and professionals 78%. And the key lessons in this process first was we learn, this is a completely new field, we have to learn in the process to prepare a public tender that will fit better with our expectations. We can see perfectly the high potential to reduce the administrative burden, because this is reducing the time of a screen of family doctors and primary care nurses, and more time to see the patient. And also something that is absolutely fundamental is to integrate this solution in the primary healthcare center, which is not the case now because this was tested with different companies. But once the public tender is finished, the solution should be integrated in the electronic health record. I think these are the two examples that in the AI domain we are testing in primary healthcare. There are many other initiatives along the system, but I wanted to emphasize the fact that if we introduce these new technologies connected with reform process to uplift the performance of centers, improve accessibility, improve quality and satisfaction, I think is a win-win process. I leave it here. Dimi, over to you.
Thank you very much, Tin. Really interesting. I love the point about integration that you made. This is key. We see that it needs to be. It can't be something separate that needs extra effort and doesn't also communicate well. Then that it defeats the purpose. 2 points that I'd like to highlight. One is the this positive additional effect that you mentioned in the first example of being able to monitor training needs. I think that's quite useful to think about when we think about the health system perspective and how these tools can help us in more ways that perhaps at face value when we think about why it is that we're introducing them. So that's really nice, and maybe we can talk about that a little bit more later. And the other point to link us to the next presentation is this different score in satisfaction in the second example between the patients who were more satisfied than the providers. And I think here again, a very clear point about trust from the public and understanding to make sure we use these tools right. So thank you for this. And I'll take this point exactly about how we engage the public, how we involve the public, how we make sure that people trust AI, to introduce Benoit and his example, because he will give us exactly that perspective from a slightly different point of view. Over to you, Benoit.
Thank you, Dimitra, and thank you for having me. So my name is Benoit Verhulst. I'm working for Mission Publique, a small consulting agency. I feel like a little bit as an outsider here because I don't have any expertise in health nor in AI, but I bring with me the expertise of 60 randomly selected citizens who took part in a citizen assembly on the topic of AI organized by the Belgian government in 2024. So we get here the voice of people that are maybe not often taken into account while bringing new policies or taking a new politics. So it was 2 years ago. It was on AI as a whole, but they were very quickly focused on the question of health. And to be honest, there were a lot of debates about that, mostly strangely maybe, between young people and elderly people. There were a lot of discussions on whether AI can be more objective than doctors, or whether we should use AI as a first-line healthcare systems, or maybe later on in the process as a support of the doctors. So it was really interesting to see all those dimensions of health discussed by randomly selected citizens. I will focus myself on not the remarks of the citizens regarding the role of AI in the global health system, because I don't have time to, but I will focus on what they have expressed regarding what affects them as patients regarding the health system, but also regarding their relations with the doctors. So I will mostly talk about a patient perspective on the use of AI. The key message they have, and it's in the report of the process, is that AI should not replace a human. That's a good start. That's a relief. They clearly mentioned that there should be always a human in the loop, and I will come back to this principle, and that AI should be used as a support, really, to the health system, but not as a replacement. I will now focus maybe on 3 different dimensions in which AI could be used following what the participants have said in this process. Firstly, they mentioned that AI could be, the original AI tools can be used to help people understand better their illness, or maybe the diagnosis of the illness, or the explanations from the doctors. Sometimes it's really difficult to understand because of lack of knowledge, because maybe some doctors are not really self-explanatory. So AI could be there to help participants understand the issue and how to cope with an illness. And on that point, participants also point out to specific publics like children's or maybe people with mental illness, where they say, okay, here AI could be a support of the doctors to explain what is the situation. But as you may have noticed, they clearly say that doctors should always be there to guide the patients into using this AI or not. So here, first, AI could have an inclusion dimension, let's say, on the access to the health system and to understanding the health system and the illness. Second point, participants of this citizen assembly mentioned that more artificial intelligence into the health systems should free sometimes to the doctors to spend more time with their patients. So they say that AI could be used to reduce administrative burden or administrative task so that the doctors could spend more time with their patients. And they mentioned here the importance of the human contact, really a physical contact with their patients, with the doctors. And they point on particularly to the role of what we call in Belgium the treating doctors or the family doctors, for instance. They also mentioned, for instance, that the emotional impact of an illness, of a diagnosis, cannot be covered by an AI. And sometimes it takes some time for an expert, a specialist, and doctors to explain clearly the situations to the patients. Sometimes they don't have this time, and AI could give them more opportunity to do that. So in that sense, participants mentioned that it could increase the well-being of the doctors, the well-being of the patient also, and it could also help reducing some costs, like more in economic perspective on how much time the doctors can spend on helping patients. And my last point is the fact that there should always be a human in the loop. There should always be a human at each step of the process of a medical process. So at the beginning, during the diagnosis, but also during the treatment and the follow-up, we cannot only rely on AI to do that. The AI can be a support of the doctors, but in the end, it's always the doctor who takes the decisions. And he can use a dedicated AI tool only for him, for his analysis and his diagnosis. But AI should not be the first contact point nor the end decision maker. And it's a matter of transparency, trust, but also accountability, where the people felt that AI it's better than human makes mistakes than AI make mistake because of accountability. So just to finish, there were a lot of debates. I just give you a glimpse of the results, but we already see some clear limits on when to use AI in health.
Thank you very much, Benoit. That was very clear and I think also very, very useful. We often forget to exactly think about what the people for whom this is actually intended in the end, if we think about our goal for better health, on how they engage with the technologies we introduce. So this is crucial. So thank you again. And let me ask now all of our panelists to switch on their cameras and come back into the virtual room. Let me ask our participants to make best use of the chat box that we still have on to add their questions and their comments. And let me turn to Erica, who will give us a sense of what has already been happening in the chat box. Erica, over to you.
Hello, lovely chat box today. Loads of people joining from all around the world. Very, very lively chat box, lots and lots of questions. So I'm just going to throw some big ones out there and you can pick. So one of them is about evaluation. So how do we evaluate these, not just AI tools, but also these systems? And particularly where we're talking about dynamic systems, how do you evaluate a moving target? So that's one big question. Also, some concerns about privacy. That was specific to the NHS, but this is a more, universal issue. How can we do really robust vetting for commercial partners for these AI tools? What recommendations and experience do we have on that? And are there any AI tools that you wouldn't want to have in your healthcare in the loop? So more personal opinions. Is there anything that you would be much more wary about? So we've heard Benoit, that we want to keep a human in the loop. But even with a human in the loop, are there any that you would be really suspect about? Okay, so over to you, and I'm going back into the chat.
Thank you very much, Erica. This is not an easy chat to summarize. It's been interesting for me to look at it because it reminded me a lot of the discussions that we had while we were preparing the webinar, but also the publication before. So lots of different perspectives. I'm looking at our panelists. So we have evaluation of dynamic systems, vetting of providers, and any personal insights on where you think we can be sure that it's a good thing and where maybe we should not be yet that sure.
I can take the evaluation.
Yes, please go ahead, Tino. Yeah.
This is what we have presented is only 2 measures out of 25 that are introducing in primary healthcare settings, and we have an evaluation with a baseline information, and we will evaluate after 13 months, actually, at the end of the year. It will be difficult to discriminate the effect of these 2 specific measures in the entire context, but we will be monitoring how access to primary healthcare centers has improved, because we have an issue in terms of waiting time. Also, the quality of care of all professionals and primary care teams, and the user satisfaction using a metric NPS. So difficult to discriminate, but at the same time, we can see contributions because we analyze individually, more probably at the technical level, the level of comfort with the tool, both from professionals and users. So this is what we have planned for this reform process. And as I said, we are making a intervention control study with difference in difference, and we will see the effect of this measure. Difficult to discriminate, but at technical level, we can see actually when we were testing the 5 different solutions, we could see which were better adapted to the needs of clinicians. And in terms of privacy, just connecting with the second element, of course, the use of the clinical decision support tool is out of the encounter, is the doctor or the nurse using the system. So it's not a privacy element there, because there is not the name of the patient in the queries. And in the ambient scribe, the patient has to consent. So there is an element of involvement of the patient in this process, and all the information will be integrated and is integrated in the electronic health record. So it has the level of protection that has a clinical record.
Okay, thank you very much, Tino. Very clear. Yes, and I think, Martin, we come to you. You were first. You're muted yourself. There you go.
Yeah, so the first thing I would make is that you can obviously do very narrow evaluations, like how accurate an AI system is compared to humans or whatever. I think that only takes you a very small part of the way. I think what we need to be looking at is evaluating the combination of the AI system and the operator. They're a partnership. And as Paula and I have shown in other work, AI may actually improve the performance of some health workers, but excuse me, it may make other ones worse, depending on their initial level of skills. So I think the combination is really important. I think the other thing that we need to say is that we should be looking at AI as part of a system, and a system that evolves over time. One of the other questions in the chat there is, how do you avoid the risk of de-skilling people? There's a real danger that if we train the next generation of health workers where they're using AI to sort out all the routine stuff, then they don't get the experience with routine care, and they misidentify somebody who has a routine problem as having something more complicated. So I think it's the evaluation, the challenge is really enormous here. It's not simply the technical performance of the algorithm. That's completely inadequate. It is the combination of the algorithm and the health worker, and also it involves looking at the whole system.
Thank you, Martin. Really key point, of course, of the system perspective, of the skills issue that Paula also highlighted in the final slide of her presentation. It brings me back to the point in Tino's presentation on using the AI tools to actually identify lack in skills, and then go back and then, of course, make sure that professionals actually still maintain their skills that way. Point taken, Martin, on involving AI too much in the training. Josh, I come to you. When I was thinking about you actually with the data infrastructure and the continuous panel data that you were talking about actually creating and how instrumental that is for evaluations that look at a dynamic system. So perhaps this is something to reflect on. Over to you.
Thanks, Demi. Yeah, absolutely. So I think continuous evaluation is a key aspect when it comes to evaluation. So we can evaluate technologies as a one-off, and often health technology assessments might have a collection of information that we evaluate at a static level. But after implementing, for example, a technology, it's really important to carry on continuous evaluation within the population that the system is being deployed. That also sort of highlights key issues with how, if we can generalize AI tools to different populations, and is this something that needs fine-tuning when implemented into a different population? So that's an aspect of sort of how these continuous pipelines can help with the continuous evaluation aspect. And I'll just mention I think you mentioned something about privacy. So in the secure data environment, that's obviously a very key aspect is privacy, and the re-identification layer that I talked about, just to clarify, is a separate application. So everyone, if you have access to the secure data environment, that's completely pseudonymized data, and then further applications are made if you have a case for a re-identifiable project. Thank you.
Thank you, Cheshire. I'm tempted to go back to Erica because I see there is a lot of additional questions, but I see Paula has unmuted herself, so I'm assuming you want to come in. Go for it.
Yes, really quickly. Can you hear me okay?
Yes.
Yeah, okay, apologies for the earlier
No
presentation.
worries.
I just want to make a really quick comment on the commercial vetting, which I think is a really difficult one, but I did want to emphasize that it is a big challenge, particularly with one for the large language models, the foundation models. They are being developed by a very small number of companies, which are based primarily in one country. So I think this comes down again to like thinking very carefully about what kind of tools you want to use, whether you develop them in-house, whether you procurement. And I feel like maybe Tino and Justin could also talk about that, but it's also about establishing partnership with these private companies, so that it's not something that has been completely developed in isolation that you then use, but sort of you develop it together so that it's meeting your requirements and the requirements of your population. But it's something which is really important to consider, particularly in health.
Mm-hmm.
Could I just come in on that very quickly, because I think it's really important. 2 points. One is that some of these companies are headed up by people with very strange views about the nature of society and where we're going, which are completely at odds with our European social model of democracy, equality, and solidarity and things like that. So I think we need to be very careful. We need to be very careful from a European point of view of giving too much power to one particular company. I mean, let's face it, it's the United States. We already have a problem with Visa, MasterCard, American Express, the fact that our payment systems are controlled effectively from there. So that's one issue. The other issue, I think, in evaluating these schemes is that we need to be really careful when we have contracts that we have escape clauses, because we have a problem in the United Kingdom in that certain bits of government have entered into contracts with one particular company and now cannot escape from them, because in the retendering process to bring another company in would mean starting from scratch. So that's another part of the evaluation. Yep. Then we get into all the issues about fairness and bias and discrimination, because many of the training sets do discriminate and exclude groups on the basis of particularly ethnicity. So it's a hugely complicated topic.
Thank you, Martin. These are all, of course, really important issues. I also see the chat reacting in that direction, and I think it reflects also what Benoit was talking about earlier about the different types of sensitivities from the public perspective that we need to take into account. So that's really important and very good that you put it on the table. Erica, I think there are a lot of really interesting questions that have keep popping up. So maybe you care to give us a couple more. We still have a few minutes.
Okay, we've got a few minutes, so I'll do a quick fire round. Okay, so given we know that innovation is one of the things that's driving healthcare costs, AI tools, are they going to save us money or are they going to cost us money? Yeah, what's the potential for AI to actually contain or reduce health spending? So what do we do, building on what Martin was saying, what can we actually do to make sure AI reduces inequalities rather than amplifying them? And how can we assess the preparedness of health workers or indeed policymakers to understand the use of AI tools? Is there some kind of AI maturity assessment metric that people are using? And what are we going to do? Well, what are we going to do about? But what about the interaction between the health system and lay use of health tools? So people lay use of AI tools for their own health, for self-care. How do we navigate that? Are there any top tips for that? Okay. So quick fire.
Can I summarize the summary, Erica? Let me make sure I got it right. So money, reduce costs, reduce inequities, preparedness of the workforce and policymakers, and interaction between the health system and lay use of AI tools. Yeah? Okay.
Perfect.
4 elements, and I see Martin already unmuted himself. I will come to you, Martin. Everybody else, if you want to be next, just signal me. Thank you. Martin, over to you.
Yeah, so as a general principle, I think we did a report some years ago for the European Commission on public procurement in healthcare. And the key thing is that you need to, when you're procuring large systems of any type, you really need to engage with people on the front line. And I think one of the reasons we wrote this book, and we hope that it will be used, is that we need health workers, health professionals to engage with those people who are making the decisions. This has to be a shared decision-making process. Going back to my point that we should be evaluating not the systems, but the systems and the operators together. I think there are real issues behind some of these questions. There is a joke circulating, and many of you will have heard it, that someone said that I was hoping that AI would be able to do all my housework so it would give me more time for my creative work. And now I find it's doing my creative work and leaving me to do the housework. And we are getting into the situation in real life at the minute, certainly in the United Kingdom, where you've got patients going to general practitioners. The general practitioners are looking at their screen while the patient is in the room, putting data in, getting prompts from AI systems and so on. And at the same time, the patients are looking at ChatGPT on their phones, evaluating everything they're being told by the doctor. So I'm using it as a bit of a parable, really, but there is a real issue here that we need to confront these things, and they're not easy.
Yeah. Thank you, Martin. Let's link to this issue of the use of the tools by the workforce. And I think Jajat, you had maybe a point on preparedness, so we come to you.
Thank you. Yeah, so I don't think there's a single tool for measuring preparedness or maturity at the moment, but maturity assessments and AI frameworks are being developed. And I know as part of the AI Centre's work, there is an AI framework that's being used in Southeast London to understand the maturity of the system, to develop a roadmap, and to highlight key areas that can have AI enable future care. Thank you.
Okay. So comprehensive strategic co-development elements, really, really important. I saw you raise your hand before. I don't know if you wanted to come in on one of the points. Yeah.
Yeah, maybe basically on the economic side.
Yes.
In fact, it was not intended to reduce cost by the introduction of these tools. It was more the fact that we can do better, so improve quality. Also, it has an equity aspect because we can level up areas where the clinical quality is lower than others through these tools. And I would say that in the short run, we don't expect to reduce cost, but we expect to increase the efficiency and the value that we generate with the resources we have at hand. In the long term, and with the operational efficiency tools that are not those that we reported today, I think there is room for cost reduction. But now we are focusing more on generating more value, better quality, more equity.
And it was not the intention of the introduction to save costs, right? So this would be exactly. Okay. Thank you so much for that. You mentioned inequalities and inequity, and I think this is also coming up in the chat. Paula, I think maybe you wanted to come in on this topic.
Yeah, to comment on that. I think it's a huge risk, right? And it's something that we really need to have on our focus when we're thinking about AI in health. There are lots of things that we can do across the AI life cycle to try to tackle inequalities, from the training data sets that we're using to the kind of problems that we are answering, to the communication with the public, transparency. So there are lots and lots of things. I did want to highlight, though, I think for me, one of the key elements in terms of addressing inequalities is this population health lens. So while there's lots and lots of potential in things like precision medicine and individual care, I think it's important to be thinking at the system level. So the solutions that we are working towards are not going to only be available for those who have the right resources, but are going to be available for the population as a whole. So I think, it's more important to have it in our mind across the life cycle, but thinking about the population health lens.
Absolutely. And as you mentioned earlier, also ensuring that the tools train on data that's representative for everybody and not just on specific people, population groups. That's really important. We had a point which was about the interaction between the health system and the lay use of AI tools. And I think, Benoit, you're probably definitely the best placed one to talk about this. So over to you.
Yes, thank you. Maybe I wasn't precise enough on that during my presentation, but the participants of the assembly made very clear that there is a professional use of AI to be managed by the doctors, and that they don't need to really use this, to really separate what they use as their own tool and professional AI tools fed with research and some health elements. And there was a lot of debate on that, but they also mentioned that it's important to have also the lay use of AI tools. And it's because very practical reasons. When they need to wait for 3 months to see a specialist, they prefer to use directly an AI tool just by asking, okay, is this injury severe or not? That's the first point. And also what I have noticed while doing facilitation of some groups is that when one citizen has a very bad experience with doctor or with diagnosis, then he or she totally lose faith in the health systems, and they tend to think that AI is more objective and can do less mistakes. And so this layers will be, I think, in any case there, because the distrust in health can come in health systems can come very quickly.
Thank you. So it's also, in that sense, really important for the health systems themselves to engage with what tools are out there that the population is likely to use, and to ensure that this is actually founded, well-founded, and takes into account all of the issues that we've been talking about. So thank you for that, Benoit. It's really useful. We don't have time for any more questions from the chat. However, I would urge all our participants to look at the chat, because it's also an incredible resource. People have been putting in their own insights, their own examples, their own links. So you have a couple of minutes left to look at the chat. I would like to go back to Paula as our keynote speaker to reflect very briefly on what we've been talking about today as a takeaway message. So Paula, over to you.
Thank you, Demi. No, I think for me, the key takeaway is that there are a lot of opportunities. There are risks. It's not about all of us becoming experts on AI, but it's important to stay informed, to be critical, to establish relationships across disciplines, so that we ensure that these technological advances benefits many and not just a few. That would be my takeaway.
Thank you. Thank you very much. I think it's very clear this is a tool in our hands, and how we use it will make the difference. So at the system level, with governance, we really need to make sure that we go in the right direction. So thank you all very much for today. To all our speakers, to all our participants, this has been really insightful. We will be back with the Observatory webinars after the Easter break with important topics like SDGs and co-benefits, nursing and personalized medicine. So stay tuned and come back if you're interested. Thank you once again, and see you all very soon.